Good afternoon, everybody. Welcome and thank you for joining us today. This is the first event of the 2022 Institute for Implementation Science Seminar Series. The seminar series features 4 lectures with leading experts in implementation science, starting with this one and running through December. Registration for all seminars is open and the link is available on our website, which will be put in the chat shortly. We have a few quick announcements before we get started with Laura's seminar today. This seminar is being recorded and the recording will be posted on our website after the event. All participant microphones are muted, so if you have any questions or comments during the seminar, please enter them into the Q&A box or the chat box, as there will be time for questions and discussion towards the end of the presentation. I'll now hand it over to our Institute co-director, Dr. Maria Fernandez, to introduce our speaker. Thank you.
Thank you, Ricky, and thank you everyone for joining. It's my distinct pleasure to introduce esteemed colleague and friend, Laura Damschroder. She's an implementation research and mixed methods expert and a leader in advancing the field of implementation science. Laura is the lead developer of the Consolidated Framework for Implementation Research, also known as CFIR, and it's one of the most widely used frameworks in implementation science. She more recently spearheaded the development of the updated CFIR 2.0. She's a research investigator with the VA Ann Arbor Center for Clinical Management Research, has been a visiting scholar to many institutions around the world, led national workshops, and is a mentor for many early career implementation researchers. So turning it over to you, welcome, Laura.
Hello, thank you for the invitation to speak today. I'm going to be talking about applying theory, but in the form specifically of the Consolidated Framework for Implementation Research, or the CFIR. And it will highlight changes to the updated version of the framework, and then also just kind of talk about an underlying theme or kind of through line in the presentation today will be optimizing and optimal and equitable outcomes as we're doing evaluations using frameworks like the CFIR. So I just want to start off just to kind of, so we're all on the same page, that within implementation science, we're typically working from what I'm just calling a generalized implementation theory. This is like just a meta theoretical kind of frame that we have, and that is that we have evidence, we have known knowledge, evidence-based innovations that that we're really looking to implement. And as a science, we tend to be kind of top-down, but a lot of the challenge within implementation science, of course, is amplifying the voices of people at the front lines and then also patients in this process as well. And where does that evidence get generated is really a topic for a whole nother session. We could talk about that. But let's just suffice it to say that there is some level of evidence available for an innovation, and we want to see it implemented. We want to see it routinized within clinical settings, and primarily we're talking healthcare, but there are many, of course, the same kind of work is going on in school systems, in communities, in many other types of settings. But I know the audience today is healthcare, so that will tend to be my language. And then we need to have effective implementation processes to help get those innovations into routine use and embedded and implemented within the clinical setting so that patients benefit from the very best treatments available. And we want to sustain this implementation. It's not just a short-term horizon. And then we also recognize that it takes, of course, it takes individuals. It takes individuals working together, ideally as teams, but then the people involved in implementation and informing implementation are embedded within inner settings, for example, clinical settings, primary care clinics, which are themselves embedded within what we call the outer setting, and this could be the kind of the socio-political, ecological environment within which the clinical settings reside. And so we recognize that there's a dynamic occurring through this kind of multi-level dynamic complex process of implementation. And this is arising in the form of context and what we call context. And these are typically moderators that definitely, these are factors, barriers, facilitators, determinants that moderate the relationship or our ability basically to have successful implementation every time. So every one of those, you know, the relationship between the innovation and the process that we use to implement, the innovation and the outcomes, and then ultimately for patients, these all are moderated by contextual features. And of course, those features are not fixed over time. So there is the word equity in the title of my presentation today. I have to have a disclaimer and say, I am not an expert in equity. Clearly, as you know, I have worked in implementation science for quite some time, but my focus as a researcher has not been in equity. And so what I am doing today is giving some reflections from a non-expert. I'm going to make a call at the end of this to kind of bring it together in the larger picture and the larger challenges that we have in addressing equity in the work that we do. And I want to call us all, and including myself, to amplify and collaborate and amplify the true experts in equity, because there are experts that have been working on the topic of disparities, equity, justice for decades. And it is past time, way past time, to centralize or to center that work and to center those researchers. I am going to be drawing off a paper that was led by Alan and colleagues with Brooke Cunningham was a senior author on this paper. And this was a group that applied a race or racism conscious, or I'm going to call it a lens, to adapt the CFIR to a specific school-based implementation. And the principles, of course, apply in healthcare. And one of the things that they highlighted is that there is potential danger of so-called race-neutral theories and frameworks like the CFIR. And what I found really interesting about this paper is that they actually did a two-step process in applying the CFIR. First of all, taking the what they called the race-neutral definitions of each of the constructs within the CFIR, and then they pushed it into a second stage of exploration for each of the constructs and explored the role of racism and how that kind of manifests and how it explains and how it may make certain constructs important that otherwise would have remained in the background. But using these race-neutral theories that these authors assert that, you know, really, you know, it can cause us to fail to measure what matters. It can cause us to fail to understand or identify barriers that are related to racist structures and systems because we don't see them. We're so used to working with them. It's like the air we breathe and the water we swim in. And so unless we're really conscious and self-reflective, it's hard for us to see those. We may lose opportunities to address discrimination and inequities. And even worse, we may perpetuate and deepen existing discrimination. So what a slide to start with as I kind of go into talking about and applying the CFIR framework. And I do this intentionally just to get us all thinking about and being more conscious, I guess, of the ways that we either promote or not equity in the work that we're doing. The second thing that, or kind of foundational concept that I want to convey right at the beginning is we need to push ourselves into theory building. So rather than only doing theory informed work, so like, for example, I'm going to use the CFR to identify barriers and facilitators, and then I'm going to use that information in various ways to improve or inform or guide implementation, either prospectively or explanatory retrospectively. We can't stop there. That's just a one-way street. We need to have a bidirectional dialogue, like a continuous dialogue between the theory that we're using, for example, the CFR, and then empirical findings and experiences based on our use of frameworks like the CFR. And so the updated CFR that I'm going to talk about, and by the way, we're not referring to this as version 2 anymore, and this is based on reviewer feedback where, and I think that, you know, this is a really important point, that this update is based on users of the CFR through their experiences, through their recommendations and critique. And it was hard to find a lot of critique. Only fewer than 20% of the published articles that were included in our review that helped to inform these updates included recommendations. And then only a small proportion of those were really substantive critiques or recommendations. And so we did do a follow-up survey with the authors of these published articles, and I don't have the numbers here. It's something like 150 or 60 authors, 40% of whom responded with very detailed feedback on a construct by construct basis. So this really is an update of the existing CFR. It is not going back to the literature and doing a systematic review of the literature. And our goal was not to expand the framework to include all of the other frameworks that have been developed since then, but rather to improve and refine and evolve the CFR itself based on user experience with the framework. But we need to have this, and I just want to take this opportunity that for anyone using this or any other framework to please publish critique of that framework, even if it's in an appendix. But this is really important information to kind of close the loop so that we can continue to build and improve on theory. For example, just one place where we really need to push ourselves to go are the relationships between constructs. The CFR has no theories around how are these constructs related, what are the how to prioritize constructs, etc. So we still have a long way to go. But all of that said, based on input from users of the CFR, we have already a published article in Implementation Science. We refer to it as the CFR Outcomes Addendum. And this article was motivated in part because of the recommendations for users to add a domain to the CFR to include outcomes. But we saw that as outside the scope of what the CFR is meant to do as a determinant framework. So as a determinant framework, it is designed to identify barriers and facilitators that can help explain and help us navigate implementation. Outcomes may be defined at many different levels. There are innovation outcomes and there are implementation outcomes. And I'm going to go into this just a little bit, but we wanted to make conceptual distinctions between different types of outcomes and different types of determinants that predict or explain those outcomes. So another concept that I want to bring in, because we did want to talk about optimizing outcomes. I really like this paper by Fontila, Schwartz and colleagues that talks about starting. Their paper is really around how do we manage the tension between the need for fidelity to the original design or the original intent of the innovation that we're implementing, the thing that we're implementing, versus the need to adapt so that, both the innovation itself and also adapting context where appropriate. So for example, work processes may need to be adapted. It's not always just the innovation itself that is being adapted. And then of course we need to identify and tailor and adapt appropriate implementation strategies to achieve optimized outcomes for important constituencies. And what these authors assert is that really we should start with the value proposition. What is the value equation? And drawing on sustainability science and authors or researchers that have written about sustainment and what it takes to sustain outcomes, this is a very important part of the process up front, is to understand what is the value proposition or the value equation. Who are the people that we are seeking to benefit, and to be very explicit about those as goals. And so when we talk about outcomes in our outcomes addendum, we suggest that there are three kind of high-level constituencies that we really need to pay attention to when we're creating our value equation for the work that we're doing. They're the key decision makers, who these are typically the executives, system leaders or executive leaders of a clinic. And honestly, of course, they, the business, the goals, whether it's a for-profit or a nonprofit entity, they have to show efficiency, return on investment, and even political capital, which we don't talk about political capital, but kind of the political landscape can really drive, and we're really seeing that so strongly through the pandemic in particular, just how important it is to understand those potential types of outcomes that these key decision makers are being held to. And then when we talk about, and now I'm bringing in this paper from Allen and colleagues, where they were working in a school setting, and they didn't articulate the outcomes exactly in this paper because this is a formative evaluation article, but they're obviously looking for school outcomes, for graduation rates, for wellness of students, and they're doing this, and they're wanting to improve those types of outcomes through community partnerships. And so for the deliverers, who would be teachers and principals, for example, who are working with this program called Project Trust, they are really interested. They can't do their work unless they have community partnerships. So that's a very proximal outcome that would be very important and satisfying and empowering for those deliverers. So like in healthcare, when we're working with physicians, we're especially in the last handful of years, we're working with so many people who are covering multiple positions because of vacancies and turnover. And so anything we can do to make their work more efficient, and so that they can really focus on their patients instead of other non-patient work, for example, those are important, just proximal outcomes to keep an eye on, and where we could make a difference as implementers. And then for recipients, which include in this study would be youth or students and parents indirectly, but looking for measures of wellness, looking for measures of connectedness. And these are kind of less traditional measures, but I just want to open the door to be thinking about, beyond medical measures, beyond test score measures, which are fraught, in and of themselves within the education setting. So the key here is, and the point that I want to make with this graphic here, is that it's important to have multiple levels of outcomes, both in terms of immediate and then long term, that people can see, and that really has value and meaning and impact for it, at a minimum, these three constituencies. We often focus just on a single patient outcome that may be a longer term outcome, like reducing blood pressure. It looks great, but patients don't necessarily feel a reduction in blood pressure. So what are other outcomes, for example, that patients may be benefiting patients in ways that they can see and feel, and the same with physicians. Okay, so then there is the idea of the determinants of the innovation outcomes, and these typically are patient characteristics. And within implementation science, we tend to focus more on implementation outcomes, because unless we have successful, effective implementation, it's going to undermine any outcomes that we think we would get or are expecting from the innovation itself. It can be the best innovation on earth, of course, but if it's poorly or badly implemented, it could even cause harm, let alone not achieving our expected outcomes. And so in this outcomes addendum, we make this distinction in that there are anticipated. So for example, we want to do things in a way, we want to do implementation in a way that creates sustainable behaviors that yield the outcomes that we want. And then we want to measure actual use over a long period of time, a sustained period of time. That would then lead to optimal outcomes. So both anticipated and actual. And then coming back to this value equation, then again, looking at the kind of the tension between the innovation and context, and that it's important to find that fit. But when we're considering the context within which implementation is occurring, the CFIR is all about identifying, helping to explore and understand and identify barriers and facilitators to implementation. So these tend to be collective level, within organizations, within clinical settings, within schools. These are the determinants that of our focus. And so, of course, the remainder of my talk, I'm going to talk about these implementation determinants and the role of the CFIR in helping us to understand those. Our fundamental research question within, when we're using a framework, a determinant framework like the CFIR, is a race-neutral version of that question would be, what are the barriers and facilitators, i.e. determinants, to implementation? Alan and colleagues actually had a more specific question because they were implementing an equity-based program. They used what they called a public health critical race praxis, which is based on critical race theory, as a kind of racism conscious lens to their work. And so their basic question was, how does structural racism, which I have their definition of it below, how does structural racism interact with implementation and innovation outcomes? So this is a question that is definitely going to uncover different things and cause us to look in different corners than just coming in and asking what are barriers and facilitators more generically. So the CFIR was originally published in 2009. And like I said, there's an update that is under review. We're kind of nominally calling it, U2 for shorthand, user updates. It's U for user, U for update. And hopefully it will be published soon. We're getting toward the end here. So the first domain of the CFR has 5 domains, and the first domain are characteristics of the innovation itself. So for example, complexity, the more complex the innovation is, the more difficult, the more challenging, the more intricate the implementation is going to have to be. And we're really drawing on kind of a combination of reality and perceptions, because perceptions really play a very important role. So, but before we elicit perceptions of the innovation, we need to define what the innovation is. And in the updated CFR, we have more explicit guidelines for every domain to encourage users to strongly encourage users to be very explicit about defining each of the domains. So for the innovation, we need to know what is the type of innovation. For example, is it IT? Is it all behavioral? Who's delivering it? What are the components? What are the, we often we rarely have enough information about which components of the innovation are adaptable and which ones are core. Like we can't touch those, because if we change them, then it's going to either undermine outcomes, or it's going to be a different innovation. So, that's always the trick with adaptations. So the CFR basically calls for an interpretive approach to context assessment. And what we've done in the updated CFR is that we have recalibrated all of the definitions. The definitions were not consistent in CFR 2009, the original one. Many of the definitions were kind of calling for descriptions of a concept or a construct. But what we've done now, and then others of the constructs, it was kind of a mix. Others constructs would basically be articulated in a positive way. So it was, some of them were the degree to which, for example, I have an example here, innovation evidence-based. So we want to know the degree to which the innovation has robust evidence supporting its effectiveness. And so this is, maybe a combination of the number of trials that show positive results. It could also be pure perception based on I as a clinician or I as a school teacher, my experience with similar innovation, or maybe I heard from a friend. And even though, those sources we can argue about, they can have very strong influence on our ability to implement, and would certainly help guide us to the need for showing and having a dialogue about the available evidence if it turns out that this is a gap. And then the other thing too that I will bring up, I think later too, is looking for heterogeneity in these perceptions. So for example, academic physicians may think that there is a very robust evidence base for the innovation, but maybe nurses in rural clinics are not at all convinced about the evidence base because their patients are different, or their patients have other barriers, and it just it's going to be impossible to get them to engage, for example. So these are the constructs within the innovation domain. There were very few changes in the updated CFR. So these are largely the same constructs, but we put the word innovation within each of the labels because we wanted users needed more clarity about to differentiate these constructs versus kind of broader measures or explorations of attitudes and knowledge. These are very particular concepts. These constructs are very particular to the innovation itself. So the guiding question within the innovation domain is, first of all, to define the thing being implemented, and we highly recommend use of a reporting guideline to guide that description. And then what are the perceptions about the innovation? So for example, I'm going to talk about Project Trust from the Allen and colleagues article. The goal with this Project Trust was to increase school connectedness for better student outcomes. And the components, kind of high-level components, included the teacher professional development, school uptake of connectedness activities and kind of approaches, strategies and approaches, both with youth and with parents, and that parents and youth, for that matter, would be involved every step of the way. Those were the main components. And then we want to, the CFR guides us through asking about the perceptions of the properties. And I already mentioned the importance of capturing heterogeneity between key groups. So for example, groups that are historically excluded, and this can be on the delivery side. So maybe it would include, med techs who are might play a key role for delivering an innovation versus physicians. And that difference is really important. And especially if there are, kind of racial differences, or, if that plays a role in the perceptions and the willingness of different professional groups to support the implementation. So I'm going to move into the individuals domain, which is the second main domain within the CFR. And within the updated CFR, we've divided this into two subdomains. And the first subdomain are the roles. And basically what we've done in this updated version of the framework is that we have moved all of the roles into this domain. So I'll go through them all in a minute, but in the previous version of the CFR, we had leaders in the inner setting, we had patients in the outer setting, and we had many other implementation specific roles listed under process. But what we've done now is kind of gather them all together in one place, because we really want one of the features of the updated CFR is that it is much more supportive and really kind of invites users to center human beings throughout, both in terms of participating in implementation, and then also who is involved, who gets to share data, who gets to share their opinions and their perceptions when we're doing interviews and data collection. So the first, I'm going to just start at the bottom of the list, and with the innovation deliverers, which includes physicians in the case of clinical care, or teachers maybe in the case of school settings, and then recipients, which may be patients within the clinical or healthcare, or students, for example, within schools. And we know that, this really is kind of the center of healthcare, or the center of education, where are the interactions between the innovation deliverers and the recipients of that innovation. And then the next group of roles includes implementation specific roles. So this includes facilitators and leaders and team members, and then other forms of implementation support that are specific and unique to different approaches or settings. And then the next set of roles includes leaders, so formal leaders who are at high level versus mid-level. And we really needed to make a distinction between these two different levels of leaders, because a lot of times people will know what the perceptions are, or what the, kind of the degree of commitment, motivation, capabilities of their supervisors, but not necessarily what people in the C-suite, what people in the, the CEO or the vice presidents are thinking. And then there are the informal leaders. These are the opinion leaders that people look up to and are influenced by. And then for each of those roles, so if you imagine kind of a two-way matrix to identify what are the key roles for this particular implementation, And then what are the characteristics for each of those roles? So for example, with recipients, what are their needs? And for deliverers as well, those are really the two key constituencies to understand near-term and priority needs. And then what are the capabilities? So like in the case of an implementation lead, what is their capability? Are they capable of, what are their skills for being able to push implementation forward, to organize both people and processes for successful implementation? And then there's opportunity. And by the way, these last three characteristics are based on Susan Mickey et al.'s framework, COM-B framework. So these capability, opportunity, and motivation all have a window or a portal into the theoretical domains framework, which has over 70 different constructs related to individual characteristics. The CFR, we didn't want to reinvent the wheel with respect to individual characteristics. But one of the things I just want to highlight about opportunity, we have kind of a highlight within this characteristic of opportunity, whether the organization provides sufficient time and sufficient authority, for example, to be able to accomplish implementation goals. Guiding questions within this domain are, first of all, to identify the broad range of people that we need to involve in some way in the implementation. And I just wrote a few roles from the Allen et al. Project Trust study. And you can see that some of these roles are in the inner setting and some are in the outer setting. And that's the other thing about the updated CFR is that, for example, leaders, there may be key leaders in the outer setting that are super influential and have authority, from outside the organization. So the updated CFR basically gives users the freedom to identify those key roles regardless of where they are actually residing. So here's an example of some findings from the Allen et al. Paper. So looking at school principals, opportunity characteristics. So the race neutral question basically is what is their capacity to implement trust, the trust program. And then the racism lens, or the critical race theory lens, is how was principal agency increased or undermined? And they found that there was a lack of agency that was used as an excuse not to act, and they may blame, some blamed unions or mandated trainings, et cetera. And then disenfranchised leaders would led to or was linked to lower relational connections and access to information and knowledge. So they began to kind of link multiple constructs together. And again, with capability, the general question is what's the capability? And what they found was that there were kind of key leaders that were very uncomfortable. They had discomfort in addressing structural racism, especially when thinking about the role of the school. And then that led to, kind of undermining efforts. The next domain is the inner setting, and again, encouraging users to define what the inner setting is. Whether it's a hospital or a system or a school or a city. There can also be multiple inner settings, and this was always the case, and I'm not going to get complicated about that, but there could be multiple levels of setting as well. But it's important to define that up front. There actually surprisingly aren't that many changes to the inner setting constructs. Those users were fairly satisfied with those. I will say that one big change, there were a few significant changes. One is with culture, we consolidated learning climate into basically a learning centered culture. And then we also broke out two or three other subcultures or types of culture. And they're all around kind of human-centeredness, equity-centeredness within the inner setting. The other change is that we no longer categorize constructs under concepts of implementation readiness versus climate, because there really was no definition or agreed to definition of those concepts, which are actually functions of a mix of constructs that really need to be determined empirically. And we explain all that in our CFERS outcomes paper. So moving on, our guiding questions are, first of all, in defining the inner setting, where will implementation occur, and where will the innovation be delivered over the long term? And then, of course, what are the barriers and facilitators within that? Within the Allen et al. Study, they were implementing Project Trust within middle and high schools in Minneapolis. And some other examples, so when their use of relative priority, their basic race neutral question was, how important was trust in comparison with other initiatives? Using a lens, a critical race theory lens, which priorities was trust compared to? And what they found was that there was a racialized aspect to perceived feasibility that led to student suggestions being ignored. So if they felt like the student suggestions were not a priority within the organization, then they would ignore those recommendations. And then in terms of culture, the race neutral question is basically, how does school culture influence or related to student and parent voice? And they found that there were schools that had an openness to change versus resistance to change. And you can imagine openness to change would be more open to listening to parents and students and their recommendations for improvement. Using a critical race theory lens, it was more specific about, or at least it was implied that they really explored whether self-reflection was, kind of part of a culture and whether it was accepted and encouraged. And they found that, in places with an organizational history of an inability to address issues of racism led to student input, again, student input not being taken seriously. So those are kind of two different dimensions of how racism potentially plays a role in their ability to implement the program. Now moving to outer setting domain. This domain has a lot of changes, mostly by adding constructs and renaming constructs. Again, we recommend that users define the outer setting. And one thing I just want to say is that it's most important to identify the boundary, the conceptual boundary between inner and outer setting. And there aren't any right or wrong answers as to where this definition, this conceptual line should be. And we recognize that it kind of changes and shifts and it's porous. But in terms of, bringing clarity to your work, how do you define that boundary for the purpose of your particular project or your particular study? A lot of times this outer boundary of the outer setting is very diffuse because there are regulations coming in from the federal government level. There are ordinances maybe at the city level. There are, quality metrics or performance expectations at the system level. So these factors in the outer setting are often coming in from very different sources, but they're all emanating from outside of the clinic or outside of the school. So the constructs that we have within the outer setting in the updated framework are critical incidents is a new one. This is, For example, an unplanned pandemic and kind of stoppages in our study, in our work. And then local attitudes that specifically include issues of discrimination. There may be, kind of a community bias against working in certain neighborhoods. Local conditions, so this is looking at, what is the built environment within neighborhoods, and again, especially looking at differences and how those may play a role in our ability to implement. Cosmopolitanism is kind of a fun word, but no one understood what that meant, so we renamed that to partnerships and connections. We've included now, we had a construct, it was I called it the kitchen sink construct within the 2009 version, the external policies and incentives. And what we've done is we've split that out into policies and laws, financing, and then external pressures, whether they're societal, market pressures, or performance measurement pressures. So those are the new, and there are many, kind of issues of discrimination that kind of go through each of these, many of the constructs as well. So there's more explicit acknowledgement. Within the outer setting, again, the key question really is defining where the outer setting begins. For this particular study, the Project Trust study, it was the Minneapolis School District in Minneapolis, Minnesota in the US. So just giving some examples of findings from this particular study, this new construct called local conditions, I just wanted to call out the fact that the majority, and the authors make this clear, is that the majority of urban schools in Minnesota have majority BIPOC students. So, students of color. And then also Minnesota ranks last or near last on time high school graduation for BIPOC students. And so this is kind of a backdrop within, that very much influences in very large structural ways the work that these authors did to implement Project Trust. In terms of partnerships and connections, just as one example construct, a race neutral question would be, what is the degree to which school leadership at each of the schools is networked with other schools or with the district? And what they found was that there was higher engagement and higher kind of degree of connection or networking when leaders were of the same race or ethnicity group. When they applied a racism lens, so this is kind of like, stopping at, if they have the same similar characteristics, then they're more likely to be more highly networked. But applying a racism lens asks, how do race relations or racism create barriers to connections? And they found that the degree of connection was highly racialized, and that that the higher network, the more deeply connected networks had a shared set of competencies and language for discussing racism. And they found that this was an important positive influence on implementation. So the next domain is the process domain, and we've expanded this domain considerably as well. We had 4 constructs within the kind of parent constructs, I should say, within the 2009 CFR. Here, because this is a determinate framework, the CFR is a determinate framework, I need to highlight that the questions are, what is the degree to which each of these key practices or key activities that they're being done? It's not prescriptive, although it can look prescriptive, but there are a lot of other action frameworks that actually give you kind of a step 1, step 2, step 3. These are activities that kind of override or kind of ride through and on top of many of those step-by-step type frameworks. So one new construct that we added and is teaming. And this also, just really highlights the importance of teams. We recognize the concept of teamness coming out of Amy Edmondson's work and others within the inner setting with those relational connections, that construct. But then it comes out as an activity here about, we have to get away from the hero model of implementation. That's what I call it. So like there's a really gung-ho nurse, for example, who's totally championing it, the implementation of a new innovation and driving it through. And we've seen more than once, like implementing infection prevention within hospital settings, that one nurse, she's the one who's collecting the data that we need to be able to track infections and then to do the appropriate response to reduce infections. But when she's gone, or when she gets promoted or transferred to another unit or leaves the hospital, then everything falls apart. So we have to find ways to do this as a team, not only in implementation, but also in delivering for sustained outcomes. We also have introduced 2 new assessing constructs, and it seems, these seem really obvious, but our users really needed to have these called out explicitly. And one is to assess needs, and this kind of goes in with the individual's domain where we have need as a characteristic. Well, we need to formally assess needs of the people involved in delivery of the program and also the recipients. We need to assess context, and of course, if you're using the CFR, you are assessing context, but just calling that out formally. And then, of course, planning, which is not new, and engaging. And we highlight specifically deliverers and recipients. All those other roles like opinion leader and implementation leader, those roles got moved into the individuals, just recognizing those, the human beings that are fulfilling those roles and that they come to the table with their own characteristics. And they're the ones who are doing the work of, for example, engaging deliverers, teachers, physicians, so that they are on board and ready to do this as a life change, not just temporary, so that recipients can engage in the program as well. And then doing, this used to be called executing, which just plain sounds violent. So we kind of went with a more colloquial term here, and also drawing on quality improvement with the plan, do, study, act cycles. Adapting is a new addition as well, I think for obvious reasons that you would understand, and then reflecting and evaluating is brought forward from the original framework. So guiding questions for the process domain is we really need to have a description of what the general approach is for implementation. And then we want to ask for each of the constructs within this domain, to what extent are the roles doing the necessary actions for sustained implementation? And in the case of Project Trust, they were looking for a community-based participatory approach where youth and parents are involved at every step. So they literally, ideally, would be on the implementation team, and they would be on the delivery team over the long term. So kind of putting it all together, here's an example from the Allen study looking at the reflecting and evaluating construct. A race neutral question is what is the degree to which teams debriefed to promote learning and improvements? Applying a critical race theory lens would ask, how are the processes of racism made visible in data interpretations and dissemination of findings? And I'm just highlighting a couple of findings here, is that they found that people were using data in some cases, not everywhere, but in some cases, data was used selectively to support their priorities, and again, to discount student and parent input. And then in at least one case, there were instances of inaccurate data being used to portray a different story. And so I've shown that. And now just kind of coming back to the value proposition, so you can, understand easily how it's important to really keep an eye on what's important in terms of outcomes for in the project trust, the parents and students, and then working backwards to adapt over time to optimize an innovation to optimally fit with context. And I just want to kind of mention the dynamic sustainability framework, which really emphasizes the need for continued optimization. A lot of times we focus on the initial implementation and maybe, did we get an improvement, whatever the outcomes are, the goals are in a 6-month time frame or a 12-month time frame, maybe we'll even go back and measure again. But we really need to find a way to engage teams at the front line to conduct plan, do, act, study, PDSAs, cycles of change. And quality improvement, that would be, PDSA cycles of change. In implementation language, we would call that continued optimization. And we need to have continued participation by both deliverers and engagement of recipients in order to sustain and optimize outcomes. So now I just want to turn to the centrality of people. And this probably goes without saying, but just to highlight a couple of equity-focused implementation frameworks. This one by Schmalbach and et al. Has people at the center. Another equity framework with Eva Woodward and colleagues has the clinical encounter at the center. So in healthcare, we know that this is where medicine really happens. With the CFR doing a keyword kind of citation mapping, it's amazing to me, and I was very gratified to see that, humans are at the center when people are applying the CFR. And so we need to continue that, but then to dig in even more deeply, because, when we need to integrate, not just, so like in the case of Project Trust, that was an intervention specifically to address inequities. So their goal was to improve disparities in student outcomes. We don't always necessarily have disparities as a primary outcome, to address disparities as a primary outcome. But I just want to assert that issues of equity, potential issues of discrimination, racism, need to be centered in all of the work that we do. And I showed examples of how one research team centered equity or issues of racism across every construct within the CFR. So the CFR framework provides what they called race neutral definitions, and they're meant to be generic. It's the design of the framework, but we need to push ourselves to apply those with a lens of equity. And I thought that study was a great example of a success in doing that. So now I just want to end with, kind of taking a step back and looking at the wide world. This paper by Lett and colleagues is really an important call for all of us in conducting research, all of us in the scientific domain, to be careful about engaging in equity tourism. And they define equity tourism as investigators who don't have prior experience or commitment to health equity research we may want to, and I put myself in this category because, like I said in the very beginning, I am not an equity expert. And, I want to jump in, I want to parachute in and fix it. I mean, that's like our first reaction. And there's so much attention, especially since George Floyd and, all of these other things that we're just all collectively becoming much more aware of and feeling a sense of urgency to fix it. And concomitantly, we're also getting increases in, public attention, priority, and resources, i.e. funding for projects that with specific equity aims, which is great. But all of this can be reactionary rather than prospective. And it's, this has taken centuries to get us to where we are, and we're not going to fix it with a 3-year funded study. So we have to commit ourselves for the long term and really, rather than just adapting, our current structures in research practices, to really focus on what are the ways that we can transform infrastructure for sustainable health justice or for justice within the research domains that we're working in. But equity needs to be a core goal of all research. And I think that with the help of Allen et al., we're able to see that science is not neutral or apolitical. And we think we're being race neutral, but we're not race neutral. And one of the things when we think about the structural, kind of structural racism that is still present, first of all, we ask the questions of who is represented in our study. And there's within the kind of street activism groups that I've been a part of, there's this slogan of nothing about me without me. In other words, if we're studying, a group of people, we need to involve those people in our work. And then we need to ask ourselves, how can this work cause harm? How might this work cause harm? One of the things that I just kind of want to point out about, this is the water we swim in, and so we don't necessarily see it. Think about what our go-to journals are. So for example, JAMA has a score of 157.3, an impact score of 157.3. You may or may not know that back in 1895, the National Medical Association, the NMA, was formed because Black physicians were not welcome in the AMA. And so they created their own professional association, and they have their own professional journal that has an impact score of 2.7. And this journal is focused and dedicated to addressing medical care disparities, particularly of patients and their physicians of African descent. And so I just point this out because there are kind of privileged sources of information that maybe we don't think twice about, but we need to. And this also comes to, our positionality as healthcare praxis. So really, me as a white woman, that I identify as white and identify as female, that limits, I have a perspective, for example, from a feminist perspective, perhaps, but I cannot, speak for non-white, lived experiences. And so, and nor do I have the expertise in equity and justice research. And so we need to reach out and center and amplify those researchers who have been working in this realm for decades. And we need to truly collaborate and not just bring them in as a token. Certainly, I've got experiences being the token implementation scientist. And so from that perspective, I can understand. But we really need to bring equity experts into our work and work as collaborators. And we need to have what they called sustainability and urgency. So quick action, like our kind of push, our desire, our urgency, can lead to mistakes. It can lead to worsening discrimination. And so we need to really take the long term. And for those of you who may be teaching or mentoring early career investigators, I just really want to encourage that doing this kind of research really demands a centering of equity and to push for ways of doing this. And it's not easy, and like I said, it's it's a long road, but I think it's really exciting, the progress that we have made, and there are lots of opportunities to do even better and to sustain and build on that progress. Thank you. I went a little bit late. Hopefully we do still have time for comments. I think we go till 3:30 or 2:30 your time.
Yes, that's right. Thank you so much, Laura. That was fantastic. And you can stop sharing your screen if you want, or you can keep it on if you want to refer to something. So we do have a few questions. I'm going to go back to one that was inserted a little while ago and they say, in interventions in clinical psychology or in any field where the impact lies in the interaction between the innovation deliverers and the recipients, isn't it often impossible to distinguish between deliverer and recipient outcomes?
That's really interesting question. I'm not sure, and maybe, I see that it's Lisa Letter who asked that question. Maybe if she could come on and elaborate a little bit more. I understand that, in clinical psychology, a lot of times the innovations are behavior change. And the success of, patients or recipients of those interventions are often, very much a product of the skill and empathy and, just who the person is, who the psychologist or the deliverer is in that case. But in terms of outcomes, I mean, we do tend to think of, recipients, there is a goal, like, for example, reducing depression, reducing levels of anxiety, and we have measures for those. And then for the deliverer, the measures may be, anything from, I'm trying to think of, what are good clinician-based measures that really matter for them. So one thing that I will say, and this might be what you're thinking about as well, is that there is a positive reinforcing loop, that if my patients are getting better and their depression is improving, and I can see that I am making a positive impact, that's empowering to me. That is positive energy for me as a clinician. But until I see those kinds of outcomes, are there other outcomes that are more proximal to the way that I practice? So, can I do this with better efficiency? Is there a better way to serve my patients, using different technology, or, and what is the degree to which I'm able to actually use that? I don't want to get into measures of fidelity, like, am I delivering all the components as designed? That might be something that I, as an implementer, care about. But as a clinician, you care about your patients. So in that sense, the measures may be the same. And I will say, actually, now I've got my head in this question, I will say that the measures that matter for clinicians are more likely to match what matters for their patients. In the case of, kind of higher level leaders, they're less connected and they have other pressures that they're having to deal with. So those may tend to be different. So thank you for calling that out, because you're right. I kind of stumbled through that, but you're right.
Yeah, thank you for explaining. Yeah, I was thinking specifically of the patient needs and resources construct, because I found there's a lot of confusion over whether that means like whether the provider is motivated by patient needs, or like whether the patient actually needs the intervention, because that's pretty indistinguishable in like clinical psychology. So I was wondering if you could comment on what that construct really means, what it's supposed to mean.
So we took out the patient needs and resources construct, and we basically parsed it out into pieces, because originally that construct was, do you know, or what is, as a clinician or as an implementer, what is your understanding of what your patient needs are, and what are the resources that they have available to them? And then kind of implied in that construct and within the longer, descriptions, there is the question of, is that an accurate assessment? And then it's, does the organization or clinician respond or prioritize that knowledge? And so that particular construct actually had a lot of different pieces to it. So now in the updated CFR, we've got whether the culture is patient-centered. In other words, does the organization respond to accurate assessments of patient needs? And then we have needs for recipients within the individual domain. We have the assessing needs, so do it formally, do it well within the process domain. And then for clinicians, oftentimes in a highly patient-centered setting, and for highly patient-centered clinicians, they're going to be in synergy and in sync with what we learned from recipients. But as you know, that's not always the case, because there are other pressures on clinicians as well. And even though they want to prioritize their patients, sometimes, restrictions in the medical record or IT or lack of staffing precludes me as a clinician from being able to do what I know my patients want and what I wish I could do.
Yeah, thank you.
And it's those latter measures that I guess we're trying to draw attention to, that, recognizing, for example, that clinicians have high rates of burnout and they're spread very thin. And so are there ways that we can implement, when we're coming in and implementing a new program and adding stress to people's lives, frankly, with, even though it might be a good change, change is always stressful. Are there more proximal measures that we could do through the way that we design our implementation strategies to relieve burden, to reduce burnout in some way? And there are a number of ways that could occur.
Thank you.
Thanks.
I'm going to move to the next question. This is by Hannah Calvert. We've been conducting qualitative coding with the updated CFR based on what you shared at the D&I conference last December. Do you have an updated handout for the changes you've made since then, or should we just wait for the paper?
Yeah, that's a good question. All the way to last December, I would say that what you could do is go to Research Square. It is kind of a pre-publication web, if I get a chance here, or maybe Ricky, if you're familiar, or Maria. If you just go to just Google Research Square, and then when you get to that website, search for my name. And the first draft of the CFR, the updated CFR paper, is posted there. Go to the short definitions file, and there are very few changes from those constructs. Thank you, Ricky. So it's in chat.
Um,
The manuscript itself is vastly updated from the Research Square version, but if you just go to the list of constructs.
yeah, there are a few questions. I think that one will answer, that your response will answer. There's another question about adaptation. Should adapting go before or after doing? I thought adaptation is a pre-thought process before doing or execution. If adaptation after doing, is it more appropriate to call it modification?
Yeah, so that is a great question, and I'm just going to say yes. And also to highlight that the list of constructs is not necessarily in order, but we're sort of assuming that, you know, there's both prospective plans for implement or for adaptation that should be a part of the planning process. And then there are adaptations that need to be done in response to, like if you're, and we're very much recommending an incremental approach to implementation. So if you're putting in, you know, kind of testing on a small scale, a component of an intervention, and then you find, well, that's not working very well. We need to refine the innovation or change a work process a little bit. Then that's where, you know, more adaptation comes in. So I say both and, you know, there's kind of planned adaptations, and then there are those adaptations that often happen on the fly. They may or may not be intentional, but trying to kind of document that is important.
Thank you. I'm going to move to another question about the topic on the lenses or racism lenses. And this is again from Lisa. It seems that like many different lenses, racism, sexism, ageism, power relations could be applied to questions based on CFER constructs, making those questions more specific. Do you see advantages or disadvantages in applying such lenses or in not applying them?
Yeah, that's a great question, and we can get really tangled up in all of that. I think that the main thing is we need to be really clear about the lens that we are bringing to the work, and to you know, be very sensitive to the power differentials that exist, and that may help to inform the lens to bring. But you know, sometimes researchers do come with more of a feminist lens versus a, you know, a justice lens or an equity lens. But I would suggest that, you know, an equity or racism, I mean, the deeper we go with the roots of racism and discrimination within this country, within the US in particular, and just how deeply ingrained it is, that if we address and consider the role of racist structures, that really it would improve the world for everyone. So there are people, and then, you know, there's intersectionality with, you know, gender and race and position and so forth. And all of those are really important to understand. Again, you know, I'm not an equity expert, but I would say that as implementation scientists, we have, whether we know it or not, we're amplifying chosen voices in who's included in the work and who is informing our work. And that is a big kind of weight and responsibility, and we need to be aware of that. And I would say that it's our ethical duty to look for the voices that are not represented and that are historically excluded, and to find ways to include and to amplify those voices.
And Laura, I would just add to that, it's also who's getting funded to do the work. And I think that that's one of the main criticisms, and when people talk about this equity tourism idea, is that it's not only engaging, but it's also empowering through opportunities for funding.
That's right. Who we are, and this goes back to kind of the positionality praxis principle, is that who we are dictates by definition our perceptions and the lens that is being put to the work. And so, and if we're the, I'm the researcher that's funded to do this work, I am automatically in a privileged position. So how do we open it up to more participatory, more collaborative, kind of citizen science type of research? It goes crossways to the funding structures that we have in a lot of ways.
Thank you. There's another question. In thinking about the data burden, does CFR 2.0, and I think you told us we're not calling it 2.0 anymore, does the new CFR have any specific constructs related to the data landscape? So for example, ability to make changes in the EHR, accessibility of data to inform feedback loops.
Yes, so we include now in structural characteristics specific to IT, which of course would include the medical record structure, because I know, for example, there are a lot of innovations that involve use of IT, like wearables, data exchange, from outside the system to inform clinical care, and clinical decision support tools, whether they're clinician facing or patient facing, and there are enormous barriers within clinical care to implementing those kinds of innovations for just those, because of the existing IT infrastructure. The other place that the data piece comes is within the learning culture, is that there's, it needs to be kind of data driven. Is the culture and kind of the way of doing work, is that data driven, and are there, kind of learning cycles coming off of that? And then we have a construct of mission alignment, and this is not necessarily related to IT infrastructure or data in particular, but we measure what matter. I mean, we measure what the system has deemed as a priority. So the extent to which, the data that we're able to collect aligns with mission, as the leaders, as system leaders convey it, that has a huge impact too on what data we're able to use and develop.
Okay, and then I think the last question is quite a long one, so let's see. So I'm interested primarily in the role of caseworkers in the implementation process. I've gotten pushback that linking individual characteristics to structural influences, like structural or institutional racism, is too broad. When formulating research questions, would it be more advantageous to formulate an individual domain question and an additional complementary inner outer setting question, or any advice regarding incorporating multiple levels of CFR into research questions?
Yeah, this is getting outside my area of expertise. I highly recommend the paper that I used as an illustration throughout the talk today, and maybe reach out to those researchers. I think in particular, Brooke Cunningham, who was the senior author on that paper. I think that, there's so many variables that dictate, how to do this, but it may be we're going to, use the CFR, but then use a critical race theory or a lens of racism in the way that we explore each of the constructs. And until we really have an equity focused, version of the framework, it's hard. I think any and all of what you suggested are great suggestions, in terms of the findings from the Allen et al. Paper. They definitely found connections between, like school leaders, discomfort with discussing racism at all. You could view that as an individual characteristic, but then it had impact on their ability to build connections with youth and parents. And then that same dynamic was kind of repeated in maybe a different way, but up at the district level and their level of support. Everyone says we're supportive of equity, but then when the rubber hits the road and actually having to talk about issues of how are we contributing, how is our school contributing, to racism, that's when they started to encounter resistance points. So I guess this is a great example of find an equity expert to collaborate with you.
Great, thank you so much. I think that is all of our questions. I want to thank you again, Laura, for your phenomenal talk and really thought-provoking ideas, not only with the new CFR, but also with questions around equity and how can we infuse an equity perspective in all of our work. So thank you so much. And thank you all for attending. We encourage you to register for the next seminar, which will be on October 19th at 1 p.m. Central. It's Dr. Jeffrey Curran will be talking about hybrid approaches in implementation research and some new thinking around hybrid approaches. So thanks again, everyone.